Hello, Professor Chalkoo. Can you hear me?
Hello, Mr. Pawan. How are you? Fine?
I'm good. How are you?
Fine. How are you doing?
I'm doing good too. So yeah, we'll start up the session in a while. And before we starting up the session, I'll just have a brief introduction of Professor Mushtaq Chalkoo to the attendees and participants. Yeah. Coming to Professor Mushtaq Chalkoo, he is felicitated for the innovations in laparoscopy and minimal access surgery with a certificate of honor awarded by Government of Jammu and Kashmir. He enrolled in World's Who is Who, a prestigious publication from United States of America. He is working as additional or associate professor at GMC Srinagar from 22nd October 2017 and working as assistant professor surgery at GMC Srinagar from 2012 to 2007 and worked as permanent lecturer surgery at GMC Srinagar from 2009 to 2012. And he also worked as ad hoc lecturer surgery at GMC Srinagar from 2007 to 2009 and worked in several institutions and universities starting from 1992. Coming to his academic background, he has done with his MBBS from Government Medical College, Srinagar from 1988 to 1992 in Kashmir University, and MS from Sher-e Kashmir Institute of Medical Science, Srinagar, Kashmir in 1994 to 1997. Fellowships in laparoscopy from SGRH and GEM Hospital, Chennai, 2005. And yeah, he is a member of Northern Chapter of Association of Surgeries of India, life member of Association of Surgeons of India, life member of Indian Medical Association, and life member of Indian Association of Gastrointestinal and Endosurgeons, life member of Indian Hernia Society, life member of Association of Minimal Access Surgeons of India, life member of Society of Laparoscopic and Endoscopic Surgeons of India, executive member of Jammu and Kashmir Associations of Surgeons of India, joint secretary and editorial member of JAKASI. He is an editor and editorial board member of several international journals, and he had many scientific publications and have attended many international conferences in his curriculum. And currently he is an editorial board member of Enliven Surgery and Transplantation. He is one of the active editorial board members who have already published many of his works with us, and we wish to continue the active spirit of him for the journal. And he is going to present a webinar on endoscopic anatomy of inguinal hernia. Professor Chalkoo, we welcome you for this webinar, and yeah, please go ahead with your talk.
Thank you very much, Pawan. It's an honor to be here and joining this. You have done an extensive introduction of I'm just a student of laparoscopic surgery, and I'm thankful to you for giving me space in this and inviting me for a talk. You know, we are passing through a very bad and a very active time of this COVID. I hope everything moves safe onwards now, and we are now passing through the fasting season. I wish happy Ramzan to everybody. I welcome everybody on board. Yeah, well, you know that we are keeping busy these days by these seminars and webinars online, and this is a good way of getting updated in this time, and we are staying home and staying safe. Thank you once again, and I think I should start without wasting very much time further. I should start my presentation today, and today I think I'm going to talk on something which we surgeons don't give much attention to, but is very important because inguinal hernia as such is an extensive subject, and a lot of research has been over there, and it has lots of newer horizons to be explored. So should I go to my presentation? Should I share my screen?
Yes, you can share your screen and start your presentation, Professor.
Okay, I have clicked on sharing my screen, so I wanted to can I go to share my presentation? So how should I share my presentation?
If you click on share your screen, you will be getting three options. You can click on share, application. If you click on that application and select your PPT, you can show your PPT.
Fine. So you are presenting to everyone, but My presentation is not coming.
Yes, click on your PowerPoint presentation. Open your
Okay, I will.
PowerPoint presentation.
Should I minimize this icon?
Yeah, you can minimize it, no issues. Or else you can directly open your PowerPoint
I
presentation.
am minimizing this and I am opening my PowerPoint presentation.
Exactly. Yes, I can see now.
Fine. Is it there?
Yes, it's there.
Can everybody see it?
Yes, everybody can see that. You can go ahead with
So
your
I was
presentation.
saying, thank you. So I was saying that we are doing these webinars. This is just a way to get updated these days. I welcome everybody on board. Thank you for joining me. So I will start a talk on the endoscopic anatomy of inguinal hernia because I felt that hernia is a subject dear to me and dear to all of us because we all of us are doing hernia repairs every now and then. But anatomy is a very important segment of this subject because this is not well read and well taught in our medical school days because as you understand we have been now we have been given access to the anterior repairs, the open repairs, and the posterior anatomy, which is the laparoscopic anatomy, has to be, has to be what do you say to get acquainted with. So endoscopic anatomy is actually a laparoscopic anatomy. Actually, what we say is that inguinal hernia, as you all understand, is a subject that we have been taught in our medical school days, and we were not being taught the endoscopic anatomy. And as now we are venturing into laparoscopic surgery, it becomes mandatory to understand and know. See, there are three segments: knowing a thing, understanding a thing, and doing a thing. For hernia, it is important. We in our medical school days, we knew hernia, but we did not understand hernia. And thanks to laparoscopy, that we understand, we know what we understood, and then we are doing surgery. As you all understand, hernia is defined as an abnormal protrusion of a viscous or part of viscous through an opening, which could be natural or artificial, through the walls of its containing cavity. And the parts of the hernia would be coverings of the hernia, the sac, or the content. I am audible? Am I audible? Hello? Hello?
You're audible. You're audible to
Okay,
everyone.
okay, fine. So the
Yeah.
inguinal hernia, we as laparoscopic surgeons, if you go to textbooks, you will find there's a lot of, these classifications are there about the hernia, but we are not interested in those classifications. There are more than 10 classifications till now for the inguinal hernia. We are, as laparoscopic surgeons, we are interested to know about whether it is a direct or an indirect hernia. And what is an indirect hernia? As you all know, that a hernia that comes through a processed, defined sacs and passes through the internal ring. So in indirect hernia, you need to have a preformed processus vaginalis or something like a sac through which the hernia comes out. While as in the direct hernia, you do need to have a sac. Sac gets formed. It comes through the medial to the inferior epigastric artery through the Hasselback's triangle, which is the weakness, the posterior part, the posterior wall of the inguinal canal. So I was saying that why is it difficult to understand this hernia? We need to understand that if we look at the inguinal canal, it has got three segments. The first segment is in the peritoneal, the retroperitoneum and the peritoneum. Peritoneal cavity. The second segment travels through the walls of the inguinal canal or through the walls of the abdominal wall, and then it becomes superficial. The segment third, which is the superficial in the scrotum, and then it becomes superficial in the scrotum. So it passes through three segments, and while it is passing from the peritoneum through the inguinal canal to the scrotum, it gets a curve. It is oblique. It is twisted, which is again an anti-hernia factor. So you are not seeing the inguinal canal in single dimension. That is the reason, like you enter with a laparoscope into the peritoneal cavity, you look at the gallbladder, the whole gallbladder is visible to you in one vision, in one view. That's not true about the inguinal canal. The inguinal canal is in 3 segments. It is, you can say, separated in first floor, second floor, third floor, and you cannot see all the 3 floors in a single view. That is the reason why it is difficult to understand the anatomy of the inguinal region and inguinal canal. So no wonder that when we look at what people have talked about the understanding of the hernia, so understanding, knowing, and then doing, this subject is that way quite interesting, and that's the reason when it is not fully understood, there are many other days to explore newer horizons in this. So it would not be wrong to quote this man. He's a British surgeon, Professor Ogilvy. He says, I know more than 100 surgeons whom I would cheerfully allow to remove my gallbladder, but only one to whom I would like to expose my inguinal canal. So who is the one whom he would allow to expose his canal? Is the one who knows it, who understands it, and then who does it. So this is a very important subject that is much misunderstood, possibly because we know it, we don't understand it, and what we practice is what we know, don't understand, or understand, don't know. So if you know it, understand it, and do it, you are the surgeon whom Ogilvy will offer to get his inguinal canal to explode. I hope you understand what I am trying to convey. So that tantamounts to saying that it is important that anatomy is an important segment of this surgery. Am I audible to all, Pawan? Hello?
Yes, you are audible to everyone.
Okay,
Yes,
fine.
you are
My
audible.
slides are seen there? Okay?
Yes, very clearly we can see your slides too.
Okay, fine,
And
fine.
yeah,
I'll
I
go.
wish like to put a request to all the attendees. If you have any questions, you can put over in the chat then and there, or you can raise your hand so that Professor will be available for you to address the questions then and there. Is that right?
Okay,
Yes, you,
fine. Should I go ahead? Okay,
yeah, please
fine.
go ahead with your
So I
presentation.
was talking, say that now look at this anatomy. When we look at the laparoscopic repair, we need to understand what is the basic concept of the anatomy. The concept of anatomy. The concept of anatomy was generated by a person, Henry Fruchard. Henry Fruchard, if you know, was a person who gave it a name. He called it a myopectineal orifice of Fruchard. He didn't call it a myopectineal space of Fruchard. When he says an orifice, as we all understand, orifice means a hole. Orifice means a weakening. So he says this area is basically myopectineal, osseous. This all contributes to a weak area. This is a hole there. And this hole is to be plugged. This is the reason why it is a hole, because many structures are going from the abdomen to the thigh, from the abdomen to the scrotum or the labium majus in females. So these holes, which are different holes over there, which we will see subsequently, they make this area weak. So he finally propounded and espoused the theory that this area is weak and this area needs to be supplanted with something like a mesh. So this area has to be supplanted with this thing. Now, what is this area? This area, you all know, is superiorly bounded by the internal oblique and transversus. Laterally, you get the iliopsoas. Medially, you have the lateral border of the rectus abdominis, and from below, pecten pubis. So we have all of us do these repairs now, the tap repair, the tap repair. Now you can see in the tap repair how we make the ports, and this is how we make the ports in the tap repair. This is how we make the ports in the tap repair. But what is interesting to note is that there is another thing that I wanted to tell you is that this is something very interesting that is happening, that is quite new, that is ETAP. If you see down there, what is ETAP is extended totally extraperitoneal repair. This extended totally extraperitoneal repair is now growing, getting popularized among surgeons, because it is better over the tap, because it has got the triangulation is available, which we'll say when we'll play the video. We will show you how ETAP is different than the TAP. Now you can please pay attention to this picture. I just want you all to please pay attention to this picture. When we enter, we will see with endoscope these things. These folds are very important. If you see, this is the bladder, and this is a fold coming up. The A is umbilicus. This is in the median umbilical ligament. which is raised by obliterated urachus. Then you have 5 to 7 centimeters when you go lateral. There is another fold coming up. It is the medial umbilical ligament, which is raised by the obliterated umbilical arteries. And another 3 to 5 centimeters lateral, you have another fold, that is the lateral umbilical fold, which is raised by the inferior epigastric artery, which is a branch of the external iliac artery. So you create 3 fossae. So this is the medial fossa, median fossa. This is the medial fossa between the two, and this is the lateral fossa. From the lateral fossa, you will develop the indirect hernia because the deep ring will be here. And from these 2 folds, that is the medial and the lateral fold, you will develop the direct hernia. And then what will you develop here? Between the median and the medial, you will develop supravesical hernias. So this is the area for the supravesical hernias. And you can see in this picture, I think better would be when we go to the video, will show you this is the ring, this is the inferior epigastric fold, this is the medial umbilical ligament, this is the vas, this is the vessels, this is the triangle of doom being made here. This triangle underlying has the vessels, and that's the ominous thing we'll see. So let us go ahead and see. These are the landmarks that you will have to see and recognize before you go to see, before you go to reflect the peritoneum. Now, once you reflect the peritoneum, after you reflect, what are you going to see over there? Kindly understand that there is a rule of 3. So what are you going to see? You are going to see 3 triangles. That is the Hazelback's triangle, the triangle of doom, the triangle of pain. You are going to see the 3 nerves, the genitofemoral nerve, the lateral femoral cutaneous nerve, the femoral nerve. They are the things that come from the lumbar plexus. You are going to see 3 ligaments: Cooper's ligament, lacunar ligament, iliopubic tract. You are going to see the 3 vessels: inferior epigastric artery, the iliac vessels, and corona mortis. We will be discussing and showing you in a live lifetime video. I will be placing, and everything we will show you how it goes from and how are the things placed over there. So if you kindly take your attention to this picture. So when you this is the picture which is very important to understand. Please pay attention to this picture. What I am showing is that here, this is the pubic symphysis, and if you go 1.25 centimeters lateral, you get an elevation called the pubic tubercle, and from here onwards you get pecten pubes. So you can see this is the muscle that is going up. This is the rectus abdominis muscle, and this is the lateral border of the rectus abdominis muscle. It takes an origin from here. Now from here also there is an expansion of fibrous expansion of a ligament that comes from the pubic tubercle, pecten pubes, and goes like this. It goes towards the anterior superior iliac spine. This is a ligament, this is a tract that's called the iliopubic tract. Kindly see this iliopubic tract. This divides your inguinal region into the superior compartment and the inferior compartment. Now in the superior compartment, you have the lateral border of the rectus abdominis. There is a vessel that will come up from the vessel down there. That is you can see below this iliopubic tract you have something called as a femoral ring or a femoral canal, and this has got 3 compartments. The medialmost compartment is here, the femoral ring. It is contributed superiorly by the iliopubic tract, medially by the lacunar ligament. The lacunar ligament is again an expansion of this. If you see anteriorly from the open repairs, it will be like same thing will be there, but that is inguinal ligament. We don't see here inguinal ligament. We see the sister concern of inguinal ligament, that's iliopubic tract. So the expansions of this will come down to the pecten pubes, and it is called as the lacunar ligament, which forms the medial boundary of the femoral ring. And it has got femoral canal has got 3 compartments. This is the ring, which is the future site for the femoral hernia. Then in the intermediate compartment you have the femoral vein, and then you have the femoral artery, and outside the femoral ring you will have a femoral canal, you will have a femoral nerve. So I hope you can see this picture, and this is the deep ring and this is the superficial ring, and this is your inguinal canal. So once the vessel which forms the inferior epigastric vessel, which is a branch of the external iliac artery. Inferior epigastric artery is a branch of the external iliac artery, and this makes the lateral border of this triangle. So you can see the triangle is formed over here. This is the Hasselbalch's triangle, and this is a weak area where the direct hernia will develop. So that is in this picture we will go to see in the video to see how things look like. Now you need to understand there are many things that you need to be acquainted with. You must be hearing what is the trapezoid of disaster, and what are things like space of Bogros, preperitoneal spaces, space of Rectus. Let us see one by one. Now, and then in this space picture I am taking you, this is the inferior epigastric artery, that is the lateral umbilical ligament, this is the medial umbilical ligament, this is the triangle here, this is the where the direct hernia will develop, and this is the internal spermatic artery going down into the retroperitoneum, and this is the vas which will go down, open into the prostatic urethra, and this makes a triangle. From below it will be the peritoneum. This will make it the triangle of doom. Why the triangle is doom triangle? Because underlying are the vessels, which you have seen in the diagram below, the external iliac artery and external iliac vein. You have to be very sure that you don't tag there, that you do a meticulous dissection over there without injuring them. So lateral to this, another triangle comes out. You can see this triangle which is bounded here by the internal spermatic artery, and laterally it is open. This is the triangle of pain, which you have the nerves which I have talked, the lateral cutaneous femoral nerve of the thigh, the genitofemoral branch of the thigh. You will not see the ilioinguinal or iliohypogastric that we see in the anterior pair. So these nerves are there, and we should never tack anything below the iliopubic tract. That is the importance of knowing the anatomy. Do not tack here in this region, do not tack here, do not tack here, because the iliopubic tract will be going like this. So you have to tack above the iliopubic tract. So the space of Bogros I will show you in the video. The space of Bogros is actually the space that is between the two lamina of the transversalis fascia. We will see it in the next slide. But there is, hello, Pavan, is it audible to all of you? Hello?
Yes, Professor,
okay,
it is clear.
fine.
We can see, and you're very clearly audible to everyone.
Fine. Transversalis fascia. I would like to take a word about this transversalis fascia. Transversalis fascia. Actually, there is a lot of research on the transversalis fascia. When we were school-going, medical school days, we used that. We would understand fascia transversalis as a unilaminar structure, and this transversalis fascia is the main thing around which, if you understand the disposition of the transversalis fascia, you will understand the hernia chapter, I should say 50%. But this is the most misunderstood entity in the anatomy of endoscopic anatomy of the inguinal hernia. Let me tell you what transversalis fascia is all about. It contributes to the formation of the deep ring. It is the only thing that is nothing but the transversalis fascia is iliopubic tract is an extension of transversalis fascia. We believe that it is a unilaminar structure, but around 2011 there was a surge by the, thanks to Department of Science and Technology. We have to be wed with the science and technology, and you can see that because of the high definition cameras, we believe now it is a bilaminar membrane, and it has got an anterior lamina of the transversalis fascia and the posterior lamina. Where you exactly get these two laminas? When you go 2.5 centimeters below the umbilicus, fascia transversalis splits into two laminas. That is the reason when I will show a video in the TEP should be done in the true space of TEP. That means if you go between the anterior layer of the transversalis fascia, which will invest the rectus abdominis muscle, and posterior layer will be on the separated from the anterior layer by the peritoneum. You do not enter into the vascular space, that is anterior space. You enter between the anterior lamina of the fascia transversalis and the posterior lamina of the fascia transversalis. This is called the space of Bogros. If you enter this space, you will enjoy surgery. It will be bloodless. If you enter between the rectus abdominis muscle and the anterior lamina of the transversalis fascia, you will perform TEP, but it will be bloody. You will not enjoy. That's the reason the people who know how to enter into this space, they do not make now the space by balloons, they make space by endoscope, because you do an endoscopic visual dissection of the space, or they will make with VC port or optical ports. They know how to enter into the true space of transversalis fascia. So that is what is transversalis fascia all about. This is also called the fascia of Gallaudet, and this also contributes to the space of Rectus and space of Bogros. Now, there is a word you all must have heard about, but is not properly understood. What exactly is corona mortis? What exactly makes corona mortis? Corona mortis is not in every patient you will have a corona mortis. Kindly understand, you go to this picture. This is an endo view of making you understand the corona mortis. We have seen few patients where we could find this corona mortis. What is corona mortis? You see, this is the pubic arch. This is the pubic symphysis. This is pubic tubercle here. This is the pubic arch. You have a Cooper's ligament here. And then you have, this is the inferior epigastric artery, which makes the lateral umbilical ligament, which we have seen. This is the ring over there, the internal ring, through which the indirect hernia will come. This gives a branch in around 20 to 30%. This gives a branch, the pubic branch, which moves like down inferiorly and crosses the what is called as Cooper's ligament. And you will find that you will have an obturator vessels here, obturator artery and vein here. Obturator artery, that's a branch of the internal iliac artery. So you will have a branch. It will again give a pubic branch. The pubic branch of the obturator artery will be here. You will have an obturator nerve there. Kindly do not dissect in this canal. You will have an Alcock's canal there, in which you have an obturator nerve. So if you injure this, create too much of dissection here, you will injure the obturator nerve. Kindly understand, it lies below this iliopubic or pubic ramus, and there is Alcock's canal and there is obturator nerve. You will get a waddling gait. The patient will come to you in the first week with a waddling gait, and know that if it is so, then you have done the job. You have probably injured the obturator nerve. So you will have a branch from the obturator vessels that will go like a pubic branch, and this will make an anastomosis between the pubic branch of the inferior epigastric and pubic branch of the obturator vessel coming up, and it will cross the Cooper's ligament. This anastomosis is called the what's called as corona mortis. It's called the circle of death. So kindly understand, when you expose the what's called as the Cooper's ligament, there's a fat over it, make it clean so that you will not miss that corona mortis is not there, because the Cooper's ligament, you know all, it's the first place where we fix the mesh. So you should be sure that you don't tack it if corona mortis is over there. You place safely the tacks over there. Avoid the tacking over this. That is very interesting and important to note by this picture which I wanted to convey to you. So you will go to see the these words, as I have said, the triangle of pain. Now, what is the triangle of pain? The triangle of pain comes in the lateral preperitoneal pocket. So you can see the lateral space, lateral to the ring. You will have a space. You will have the nerves coming over there, and these are the lateral femoral cutaneous nerve. This is the branch from the femoral nerve, comes from the lumbar plexus. You have the femoral branch of the genitofemoral nerve. You have the genital branch also. You have the femoral branch. The femoral branch is importantly goes to the thigh, and the genital branch will enter the ring into the canal. So it is the femoral branch that can get injured in tap or tap, and the femoral nerve as such does not get injured, but femoral nerve has another branch, that's the anterior cutaneous branch, that can get injured. And if you tack them in this area, if you use tacks in this area, I don't know, all of us are aware that around 2012 the tap went into bad reputation. The reason was that they said that they are coming with a lot of pain and something like neuralgia paresthetica, because if you are tacking in this area, there is a lot of pain. These patients do come with paresthesias and pain in the anterior half of the the thigh, the medial aspect of the leg, the scrotum. Sometimes they are in agony. If you are causing only the neuropraxia, there is neuropraxia, there will be, or entrapment of nerve, there will be pain. But if you are totally transecting the nerve, there will be numbness. So you have to differentiate. If patient comes with pain, sometimes we have to redo or the surgery and remove these tacks. So it gave a bad name to tap and tap. The reason was because we were making these nerves exposed, trying to show in workshops. But kindly understand, do not make them naked now. Let the some fat stay there and let them sleep. And do not tack over there. This is the area that's called the triangle of pain. And this pain is very gasolgic type, which is called as neuralgia paresthetica. Kindly understand that we do not see iliohypogastric or ilioinguinal, that is L1 or L1-2, which come from the lumbar plexus. We do not see these nerves in this. So I'm opening a video. Kindly stay with this video and kindly understand that I will be trying to show you. I'm going in, doing a tap. See, I'll only show you the anatomical aspects, which is important in this lecture for me. So you can see I have stopped the video. I don't know whether it has stopped. Okay. Have I stopped it? Right. Hello? Hello?
You
Hello?
stopped it now. You stopped it now.
Okay. I'm playing again. I have stopped it again. I'm taking it a little back to show you what actually I want to show you. So please stay tuned. We'll again starting it. I wanted to show you something. So you can see this is I'm standing on the right side of the I'm standing on the left side of the patient, and you can see that we have gone to see. I will just stop it here. Okay, I've stopped it. Please now understand the anatomy, what we have talked. You can see a hole over there. This is the deep ring. So your endoscope is facing to the inguinal region. You can see a fold, this fold, which I was talking. This is the lateral umbilical ligament, and it is raised by inferior epigastric artery. Kindly see, this makes the medial border of this is the left side I am operating. So this is the left side. So this is the ring, and the ring is patulous. If the ring is patulous, it is Gilbert type 1. Though we do not believe in Gilbert classification laparoscopically, but this qualifies at Gilbert type 1 because the things can move into the canal. So kindly understand, this is the inferior epigastric artery, which raises the fold above this is the inferior epigastric fold. Can you see this fold? This is the fold called as the medial umbilical ligament. This is the lateral umbilical ligament. And between the medial and the lateral umbilical ligament, this area is Hazelbeck's triangle. And this triangle is important to understand. I will release the video. Kindly watch now. I will go to the other side and show you on the other side how the anatomy will look like. So move to this side. This is the right side of the patient. Okay, I have stopped. Now I have stopped the video. Please pay attention to this anatomy. This is the right side of the patient. This patient, you can see this is the fold. This is the inferior epigastric artery raising a fold called as the lateral umbilical ligament. You can see here is the deep ring. This side it is patent. I mean, it is not patulous. There's no hernia on this side. You can see a structure coming out like this. This is the interspermatic artery, and another structure coming medially. This is the vasa differentia. So this will make a triangle like this below by the peritoneum. This is called the triangle of pain or triangle of doom. Sorry, triangle of doom is here. And this fossa between the inferior epigastric. This is another fold here. This is the medial umbilical ligament. So the space between the lateral umbilical ligament and the medial umbilical ligament, this is the area where the direct hernia comes, and through this is the area where the indirect hernia comes. Something can pop in, and then indirect hernia develops. This is the Hazelbeck's area or the posterior wall of the inguinal canal where the direct hernia comes, and this is the medial umbilical ligament. Here is the median umbilical ligament, and the area that between the medial and the median is where these hernias can develop here also, and they are called supravasical hernias. So I will release the video and stay with me. So here we are seeing that now what are we going to do? We will dissect the peritoneum now and see the anatomy after reflecting the peritoneum. So where do you make an incision? You go 3.5 centimeters superior lateral to the deep ring and make a small incision in the peritoneum. Let the gas go in. If you can appreciate, this peritoneum only I am cutting. I am not taking this yellow thing, that is fat. That fat belongs to abdomen. Kindly understand that fat always belongs to abdomen, as fat belongs to rectum. Well, we do that surgery. Here fat belongs to abdomen. I am only lifting the thin layer of peritoneum, and this loose areolar tissue is nothing but fascia transversalis. Now the Japanese say this is a four laminar structure. They are doing a research saying that this could be a four laminar structures. The fascia transversalis is a very interesting subject, structure, which a lot of research is going on this. So you can understand now I am just trying to cross this fold. That is the fold raised by the inferior epigastric artery. I hope you can appreciate in a short while now I am reaching the vessel. So don't misunderstand this part. So right, understand it that underlying you can see this vessel. This is inferior epigastric artery, and it is always with some two veins were there, the inferior epigastric veins, the vena comitatus of the vessel. So you can see that after this we have crossed. Now we are between the inferior epigastric artery and the medial umbilical ligament. I am cutting this. Now what I am going to open up, I will open up a space called as the Hasselbalch's triangle. Now kindly understand and stay here. This is the triangle. My left hand will first open. Do not go beyond the medial umbilical ligament. Don't cut this fold. Enter and open this space. You will see the first structure. Right now you will see the first structure that will be quite whitish. That whitish structure you can see in a short while. You can see it. That whitish structure is what you called as the, yes, that's the white structure. That is the structure. We call it Cooper's ligament. So I am developing this space. I will stop the video here. I hope you appreciate. Let me just go it little ahead. Now I was trying to show you that, okay, this is the place where I should stop the video. Now please understand this anatomy. This is the inferior epigastric artery, and medially you come, this is the rectus abdominis, this is the lateral border of the rectus abdominis. This is the inferior epigastric artery, which is the raises, which makes the lateral umbilical ligament. And so this is the apex. A branch is going from the inferior epigastric to the rectus, and from below, if you see the anterior anatomy, you will see the inguinal ligament forming the floor. Here you have the pubic ramus or iliopubic tract, which will form the floor, and this is the triangle which is called as the Hasselbalch's triangle. So this is the area where the direct hernia will develop. I hope you appreciate this part, this triangle here. Now we are making a medial peritoneal pocket. Now this is the pubic ramus and this is the pubic symphysis. There are a lot of anastomotic veins and vessels who are here running. Do not rub on them. This is called as what is called as Bindavid's anastomotic circle. Now we go to the lateral peritoneal pouch and dissect the lateral peritoneal space. In between you have the sac, and this is the ring. Now I am dissecting the lateral space, and what is the idea to do the lateral space? Dissect it till the iliopsoas is visible. So the medial and the lateral space are straddled or divided by this your peritoneal spermatic cord or the peritoneal sac. In a short while now you will be seeing. So this is the medial space, medial peritoneal pocket. Down there is the bladder, and you will see lateral peritoneal space. Now what am I going to do? I am separating traction and counter traction. This is the sac in my left hand, which I am trying to separate from the pseudo sac, that's the fascia transversalis. In this patient we have done orchidectomy. So I selected this patient for the demonstration of hernia because you will see we have removed the test, all the spermatic cord, because I wanted to show you the anatomy after removing the spermatic cord. So we have done the orchidectomy in this patient and removed the testes from below by making a small incision on the scrotum. Now you can see this is the middle space. Here you will find a very important structures here, or what I was saying that this is the lateral space. These are the nerves. Can you see the nerves here? So you do not keep the fat over them. Do not. I'm just touching for showing you. Keep them there. So the superior flap should be raised. So because the mesh has to go under the superior flap. Now this superior flap has to go and take the superior flap up, and then because the mesh has to go, and then you have to repair the superior flap. Now I will just go a little ahead. Okay, and I will stop the video here to tell you something more here. Now please understand that I've stopped the video. Let it go a little more. So you separate the sac, you separate the thing. I am not going to show you how we remove this, because I want to show you after we remove this, we have to remove all this. You can see the sac, and you can see the structure, the contents of the sac. So you can see a yellow thing here. That is the fat at the deep ring, which we always say this is one of the markers of defining the deep ring. So we always remove this fat. It should be removed because this is the future site for the you can develop a lipoma over there. So once we remove this fat, you can see we clean this, remove this fat. Now you see we're doing traction and counter traction. I wanted to take you to this anatomy here. So let us squeeze the video. Now please understand, this is the inferior epigastric artery going up. This is the deep ring through this is the ring through which this sac is coming, spermatic cord is coming. This is the triangle of Hasselbalch's triangle. This is fascia transversalis making the posterior wall over here. This is the lateral peritoneal pocket, and this is the medial peritoneal. And this whitish structure over here you can see is Cooper's ligament. We will release the video to go ahead. I hope I am audible. Am I audible? And hello?
Yes, you're audible and your video is very clear. We can see that.
Fine. You can see what I'm trying to do. I'm trying to separate the sac from the structures of the cord. And now I'm not going to show you this. I will go ahead in this video. My aim to show you is that after we lift the sac, underlying are the vessels. So this is the triangle of doom over there, down. So you will see that I will separate the sac from this and lift the whole sac up. Make always sure that you lift it up, because when you are lifting and then dissecting the sac, you have less chances of injuring the vessels there. Here we have ominous things there, that is the external iliac artery, external iliac vein. So we will separate the sac. That part I will just quickly go ahead. So now you can see we are splitting the spermatic cord with the sac, and take the sac on one end, and you will see the vas will come on the other end. This all is sac. This is a big sac in this patient over here. So this is this vas on one side, and the vessels and sac will be taken. We will ligate the sac at the, here I am ligating at the base, just for you to see. I will remove this all, just ligating the sac, and we will remove this sac and all that from through the inguinal canal and making an incision down, and then we will take the sac, because we are doing an orchidectomy in this patient. We had an orchidectomy. That's the reason why you will see that. See, so we are suturing this the sac, and we will cauterize it and remove the sac. That part you can just should go ahead. So we have removed the vas also. Right. Fine. So I'll go ahead to show ahead what is my idea to show you that. So you can see the sac, I am pulling it. This is the ring. You can see I wanted to show you the ring. This is the deep ring, and this is the canal. This is the posterior wall of the canal. This is inferior epigastric artery. This is pubic symphysis, pubic arch. You have puboprostatic ligaments here, down there. Do not fiddle with them, and do not dissect 2 centimeters below the pubic symphysis, because you will have a structure here called the prostate, and you will injure the prostatic capsule. So you can see we are pushing this sac the way we have taken it through the inguinal canal and making an incision there. This is the deep ring there. Okay, we come out. Before putting a mesh, let me take you a little thing. So I will freeze the video here and tell you little more things. So before I put the mesh, let me freeze the video over here, because I want to take a look of how things appear. So I'm pushing the sac down and taking it out along with the testes. So okay, I have just stopped the video. Please pay an attention to this. Can you see this is the pubic symphysis? This is the pubic arch, pubic symphysis, pubic arch, pubic tubercle would be here, and this is the pubic arch. This is the Cooper's ligament. You have the femoral ring here below the inferior epigastric and deep ring. It is 1.25 centimeters below here. You will have the femoral ring where femoral hernia will come. And this is the triangle of, please understand, this is the triangle of Hazelback. This is the rectus abdominis muscle going up. This is the lateral border. This is inferior epigastric. And the base is formed by the iliopubic tract. The iliopubic tract will come from here, from pubic tubercle. It will go like this. It will form the floor of the deep ring and will go like this towards the anterior superior iliac spine. I will release the video. So I will go little up. So you can see this, all the structures. Now why I am showing you this is the ring. This is the deep ring, the inferior epigastric. These are the external iliac vessel here, and this is the dome area. It is beating. You can see the beating vessel over there. And the lateral space would be the triangle of doom. Here, the triangle of pain. We are not going to see them. We have seen them. And here we have, this is how the structures will appear after removing the spermatic cord. Now we are putting a mesh. This is a 2D mesh of from the Covidian possibly, and this is a macroporous mesh, and it is polyester. You can use Prolene. The size recommended, as you know all, it is 16 by 12, and it should cover, the idea is it should cover the whole myopectoral orifice of Fouchard. I'll just go really and see how we fix the mesh. And this mesh is a 2D because it should stay 1/3 down and 2/3 up, and it should cover all myopectoral orifice of Fouchard, which we understand now what exactly we mean by myopectoral. It should plug in all the holes, and mesh should be splayed nicely and properly. There should be no wrinkling in the mesh, and then you can suture. We are using the barbed wire to suture this. 15 centimeter is the best length you should select to suture back this and this, and we complete the procedure. The mesh stays in. Do not make sure that mesh does not curl in, and that's how we go. I will just take you to a procedure, another procedure that has gained a lot of now visibility. This is a procedure we are doing an E-tap. Am I audible, and can everything be seen?
Yes,
Pavanji?
you are audible.
Okay,
You are audible.
so this is a patient where we are demonstrating anatomy by E-tap. E-tap is extended totally extraperitoneal repair. You can see the patient, and you can see the inguinal hernia is here. He has bilateral inguinal hernias. These bulges can be seen, one here and one there. So he has a bilateral inguinal hernia. Now, where exactly I am standing on the right side of the patient, and this is the foot end of the patient, and this is the umbilicus. I will go 3.5 centimeters superior lateral. This is umbilicus. I'm going 3 centimeters above, and at the
We'll get into the session soon.
incisional hernia and the same sting.
Yeah,
You can do all procedures like TAR, you can do ETAP, RS, you can do everything by ETAP. That's why it has gained a lot of, the familiar, this reputation. But it needs to be done in a proper way. So what I'm doing is that at this part of the body, you don't have superficial fascia. We are above the umbilicus. So we are splitting by these two small angle detectors. We have cut the skin. You can see the skin is cut and the fat is cut. You have subcutaneous fat. In a short while, what we are doing, we are trying to clear this fat. Try to clear this fat from this, and you will see the whitish structure of that is anterior rectus sheath. So we are trying to clean the fat. You can see this whitish structure. I hope you can appreciate this white structure there. That is anterior rectus sheath. Now, after you see the
Professor
anterior,
Chalkoo, sorry to interrupt you. You haven't shared your screen.
where is
Please,
my screen?
you have stopped sharing it. Click on the share your screen again.
Where is that? I don't know.
I mean, below you have shared your screen. Share your screen option. Click on that.
I can't see that. I can't see.
It's there.
Let me. Where is the? No, I can't see that.
You have stopped sharing the screen actually.
So how
In the
can I do
bottom,
that? Can I? How can you
in
do?
the bottom side, there is a share your screen option. You have done till now.
Wait, I will stop the video. How should I
No,
do it? Should I?
need not stop the video. Click on
Right.
share your screen. That's all.
Click on where is, because everything is my presentation. Okay.
Go to the air meet thing.
Pardon?
Go to the air meet window.
Air meet window. Okay. I don't know where it is. Okay.
Click on share your screen.
Share your screen.
Bottom side. There is a symbol of desktop. You can click on that.
Share your screen. Okay.
Yes.
Is it okay? Has it
If you
come?
click on that, no, haven't come yet. Have you clicked on it?
Yeah, I have clicked it.
Yeah, now it's there.
Okay, I will go back to presentation.
Yeah. Yes. Go back to your presentation.
I was just here. Kindly stay
Yeah,
with me.
sure. Yeah. Now we can see it.
Fine. So now you can see my, am I on screen?
You're on screen, your video is on screen. You can go ahead.
Fine. Actually, this was disturbing me. That's why. Okay.
Yeah. By
I was
accidentally you have
trying to
clicked on
show
stop
you.
sharing.
Let us go. We were here. I'll take you back. Okay. No, I will. I was here. Okay. Okay. You can see this white structure. Is this again visible? Fine.
Yes.
So this is the anterior rectus sheath. We are doing an E-tap procedure. So after you see this white, you cut this white. This is anterior rectus sheath. Cut it. So when you cut the anterior rectus sheath, you will find something reddish. That is rectus abdominis. So rectus abdominis will be seen. You cut with a scissor. I hope you appreciate this fleshy fibers, red fibers down there. After cutting the anterior rectus abdominis, you can find this reddish structure. So this is rectus abdominis muscle. Now what are we going to do after this, after cutting the anterior rectus sheath? So you can see, appreciate. I hope you can appreciate this is rectus abdominis. Now we are taking the rectus abdominis to one side, and we will see another whitish structure, that is posterior rectus sheath. So posterior rectus sheath, can you see that white structure down there? That the muscle rectus abdominis has been taken to one side, and you have seen the posterior rectus sheath. Now I have in the habit of making the space by my index finger. I use quite a bit of my index finger, right index finger. I lubricate it, and we place you can see the finger is going retrorectus. So we are making this small space because we do not believe in making spaces by balloons. We make a space. We don't use VisiPorts or optical because they are very costly. We are working with finance constraint. So you see I am making a space by my index finger by just striding on the right and left. Now you can see the rectus sheath, and now we will make a space and put an obturator of the Hassan's trocar. Lubricate it and let it go towards the pubic arch. You can appreciate this is, we are trying to make the retrorectus space. So after the retrorectus space is made, we put 12 mm trocar here and stabilize the 12 mm trocar. I'll just take the video little ahead. Stabilize the trocar. Now we are entering. Okay, you are entered into a space called as the retrorectus space. So this is the space. This is the basis of the E-tap. So what is the idea? Thanks to George Dace, this is his concept that you can enter extra retrorectus space anywhere, or extra peritoneal space anywhere from the abdomen. So that is the idea, that you can see that we have entered the retrorectus space and we are going to develop it now telescopically. That is the Phillips technique. Phillips technique is the technique of making the space by telescope. Now you can appreciate, I hope you can appreciate, we are going below the umbilicus and we are entering into the hypogastrum, and since we are doing a bilateral hernia in this patient, you will see that we will create a space. We will do a midline crossover from the what you call as the hypogastric inferior crossover. The crossover can be done from below the umbilicus. Crossover can be done from above the umbilicus. From above the umbilicus, you go through the falciparum ligament, cut the posterior rectus sheath of one side and posterior rectus sheath of the other side, and then communicate. This whole space is basically one. So that is what is the concept of Rives stopa, that you can communicate this retrorectus space into one. So after you make the retrorectus space, I'm putting a needle over here and doing a needle guided 5 mm port. I'm putting so this is the 5 mm port. So we put 2 5 mm ports and do the procedure. This is 1 5 mm port. Another 5 mm port will come from the side of umbilicus. You can make it through the umbilicus or below umbilicus or above umbilicus, whatever. So what am I doing? I'm trying to create a space, pushing the posterior rectus sheath down, and this is the rectus abdominis muscle. So we will enter by another 5 mm port here, where this is, if you push the posterior rectus sheath down, you will create a space between the rectus and the posterior rectus sheath. From above, you are pressing with a finger, or we put a needle to see whether we are in this space. So you can put a needle and see whether this needle enters in this space. If it enters in this space, that yes, this is the needle. So you make a needle guided 5 mm port from outside. You can see that 5 mm, another 5 mm port will enter and will enter into this retrorectus space. So once these 2 ports are available to us, we are having now triangulation. This triangulation was not possible in TAP. So TAP is getting, I mean, not now quite many people have left doing TAP because they feel more happy because the triangulation is there. You can make a bigger space, you can communicate, you can treat multiple hernias, you can take even the incisional hernia with the same going complex hernias, and you can also put a bigger meshes which was not possible in the TAP. And triangulation and suturing can be done because triangulation is available to you, because you can see the triangle makes an angle of laparoscopy 60 degree. So this triangulation is not possible in TAP. That's why TAP is getting a bad reputation. But we keep on doing TAP also. But I think for bilateral hernias, for bigger hernias, but if you have an incisional hernia associated or recurrent hernias, this is the better technique where we go. So we are now going down to see where we are doing a bilateral hernia, so we need to cross over. So I am exactly in the right space, right preperitoneal space. So these preperitoneal fat and these vessels are there. So we will ligate them and try to create a fistula. If you do not ligate them, they will cause some messy bleeding, and that will mop up your light, and you may probably not see the things well. So you can see down there on the right side, this patient, we're trying to develop a space. This patient is having a hernia. He is both hernia on the right side. You will see the direct hernia. I will show you how the direct hernia would come. And then you see the rectus muscle is on the top, and I am dissecting by traction and counter traction and trying to create a bigger space. We have crossed the other side. You can see we have gone to the other side. In a short while now, we will be reaching to the, let me go. See, now this is the orchid line. Can you see the orchid line? This is orchid line. It is 2.5 centimeters below the umbilicus. And below this is only fascia transversalis. There is no. Can you see this whitish structure over here? This is the direct sac on the right side. And I'm going to the left side to make a space in the left side. You can see the amount of space that you can make. I mean, that is what is the beauty about the ETAP. See the amount of space, or how much comfortable you are, and how much dissection can be done. You can go as lateral as iliopsoas on either side and put a big mesh, something like we do in ETAP RS. So I'm dissecting on the other side. Let me go a little faster. So you can see on the other side, now we're trying to dissect on the other side. In a short while now, you can see the Cooper's ligament here on the right side. You can see the ring here. You can see the structures of the spermatic cord. And on the right side, he has only indirect hernia, but on the left side, you will see he had a very big hernia, which I'm going to show you just now. Stay with me. Okay, fine. You can see this is the hernia. Now, how do you call it is a direct hernia? Kindly understand that this is the pubic arch all, and this is a something going up towards the triangle of Hasselbalch's triangle. This was a big hernia, direct hernia coming medial to the inferior epigastric artery. So any hernia that comes medial to the inferior epigastric artery is a direct hernia. You can see it is going, and this all is going up and going up. So you will see that we will be dissecting it. And now this is the indirect part because the ring is here. Now this is the deep ring here, and you can see the deep ring, and these are the structures of the spermatic cord. So this is the indirect hernia here, this side, and this is the direct hernia, this one, which is plugged still up, and we had to struggle a lot to take this contents down. So you here you can see the deep ring, and you can see the structures exiting from the deep ring. Is it audible to all? Is it? Am I audible? Hello? Hello?
Yes, you're audible, and the video we
Okay,
can see
fine.
also.
Okay, you can see. Now
Yes,
I'm
yes,
trying
you are
to.
audible. Yeah.
Okay, fine. I'm taking this sac down. This is the sac of the direct hernia. This is the sac of the direct hernia. So fine. So you can see that this hernia, this is the sac. You can see, and it lies. This is the ring. So it lies medial to this. So this becomes a direct hernia, which I have shown that this is Hasselbalch's triangle through which this hernia, direct hernia, has gone up. So this we are pushing the contents down, and in a short while now you will see the contents will come down. Done. Fine. So you can see it was a very huge hernia. Contents were locked, possibly an incarcerated one. So we are pushing the contents by traction and counter traction. So I'll go a little ahead. Yes, you can see now the contents are falling down. This is the content of the. But we were worried that this could not be a something gut or something there. You can see a hole over there. Can you see this hole? You can see this big hole. This is the hole in the Hasselbalch's, and this is what direct hernia defect. And you will need to tack the pseudosac to the Cooper's ligament. This is we are pressing from outside. But we were not sure whether such a big hernia may have something inside, because you are in an extraperitoneal compartment. You don't know whether gut is there. That is the worry. So what we do, the beauty of ETEP is that you can open this sac here and then prepare it, because you can do suturing in ETEP. So you see, I am opening this sac to see whether gut is not there. We have not handled it. So we are entering the peritoneum at this place, at this stage. Nothing, your space is not going to collapse because you are equalizing the pressure on both sides. So you can see we will open this sac and see whether gut was not there. We see in a short while now. I'm forwarding the video. So fine. Right. Now this is on the other side. This is on the other side. This is the triangle of room, and we are taking the sac. A flimsy sac was on the other side. We're taking that sac also out. I hope you can appreciate the amount of space is available to you in ETEP. That is interesting to note. So you can see these are the, now if you visit the anatomy, whole anatomy once again, let us see. I hope you can appreciate. This is on one side of the hernia we have tackled on the left side. This is on the right side of the direct indirect hernia we are tackling. Direct we have seen, we have dropped that down, and this is skeletonization of the sac we've done. So I'll move a little faster. Fine. Now you can see I had said that I will open that direct sac. I have opened it. Now we are suturing that direct sac. See, this is open direct sac here, and we can suture this direct sac also. Now you can see we are suturing, and after looking, peeping into the abdomen. This is abdomen. It was only omental fat over there, nothing more. So we are suturing this defect here. So this defect can be sutured. So after suturing the defect, you can see this defect is sutured. Then we are going to revise this anatomy. This is whole space. There is some rent here also. So we are repairing that rent in the peritoneum. You can see this is the beauty about the ETAP, that you can do suturing and any rents can be closed. Fine. Now we are putting a mesh. Now in this we are putting a mesh, 3D mesh. This is a 3D mesh, the Proline. This is a heavyweight mesh and it has got a margin. This is marketed by BOD, and you can see this mesh is a 3-dimensional mesh because it is contoured to the anatomy or the orientation of the what you call as the inguinal canal. It just has to go and stuck. Even if you don't fix it, no need. And you should cross the midline 3 centimeters by putting 2 meshes. You have a blue mark there. M is written, means medial. It is for the right side. And another mesh we are going to put on the other side is the another mesh. And we will tag first at the Coopers. And then you can see the other mesh is put and the direct side contents are pushed forwards. Push this mesh down and then release the contents. Now, if you see in a short while, you will see both the meshes are being put, and you can push it down mesh and then fix it. You can see both the meshes are put and contents will stay on top of this mesh. So this is a 3D mesh, and this is a BOD makes this mesh. It's a little costly, but it is good for such hernias, huge hernias. We have a good experience of using these meshes. So fine. I think I should stop it here because the fasting season is there, and it is iftar time. I would say I'm thankful to everybody who has joined me. Just few questions, if there are, I'm ready to answer them. And I would say keep conquering and stay home, stay happy, stay healthy. And thank you everybody for joining me so long and going with me. Thank you very much. Thank you, Pawan. I hope if there are questions, I am ready to answer all of them.
Yeah. From attendees, if there are any questions, you can just raise your hand or you can put your question in the chat box so that your questions will be answered then and there. You can either raise your hand so that I can make you access, and you can raise your hand and ask the questions, or you can just put or in the chat box that will be addressed by Dr. Mushtaq Chalkoo. And that was a very informative session, Professor Chalkoo. And yeah, that was a very detailed, and your work is always appreciated because you have done a lot of good work. Yes. And he is current editorial board member for Enliven Archive, Enliven Surgery and Transplantation. And we hereby are conducting webinars on behalf of Enliven Archive and NOM Publications, which are both open access and are handling peer-reviewed journals, where Enliven Archive contains of 25 peer-reviewed journals, and NOM consists of 8 open access peer-reviewed journals. And I request Professor Chalkoo to kindly suggest the journal to your colleagues and members and students who can actually submit their versions to us and get the get their work published. And if you can promote the journal in your circle, and we can go ahead with the successful journey of the journal.
Absolutely, Pawan. Thank you very much, and thank you for inviting me for this talk. And I'm thankful to everybody who's ever joined us with, and stood with me for so long a journey of, I think, 1 hour and more than 15 minutes. And I hope I have done justice with the subject. There is much to learn more about. And thank you once again. Happy Ramadan. Happy go. Thank you very much.
Yeah, that was a good session, and it is always our privilege to have your talks and your presence in our journals. I would like to thank Professor Mushtaq Chalkoo and also all attendees for making this webinar successful. And yeah, as there are no questions, I would like to end the session hereafter. And thanks a lot, Professor Mushtaq Chalkoo, for your time and for your lively presentations. Thank you.
Thank you very much.
Goodbye. I'm
Goodbye.
Thank you. I'm ending the session. Thank you.
Thank you.
Bye.